Hello, and welcome to today's webcast, Nonconvulsive Seizures in Critical Care, the Emergency You Can't Afford to Miss. This presentation is supported by Ceribell. Hello, everyone. My name is Gretchen Brophy, and I am a professor of Pharmacotherapy and Outcome Sciences and Neurosurgery and a Neurocritical Care clinical pharmacist at the Virginia Commonwealth University Medical College of Virginia in Richmond, Virginia, and I will be moderating today's webcast. A recording of this website will be available within 5 to 7 business days. To access it, log on to mysccm.org and navigate to My Learning tab and select Nonconvulsive Seizures in Critical Care, the Emergency You Can't Afford to Miss, and then click the Access button to review the recording. A few housekeeping items before we get started. There will be a Q&A session at the end of the presentation, so please submit any questions throughout the presentation. And to do that, just type into the question box located on your control panel. Please note the disclaimer that the content to follow is for educational purposes only. And we will start today with today's presentation with just a short poll. So if you would please complete this poll. The first question is, what is your primary role? The next question is, what is your biggest challenge in detecting nonconvulsive seizures? Please select all that apply. Our next question is, which of the following best describes your view of point-of-care EEG for NCS detection? Our final question today is, which best describes your facility's current EEG access? Now, excuse me, and now I'd like to introduce your speakers for today. Each will present their information, followed by the Q&A session after the presentations. Dr. Chitra Venkatsubramanian is a clinical professor of neurology and associate vice chair of faculty affairs at Stanford University. And Dr. Brandon Foreman is an associate professor of neurology and rehabilitation medicine and associate director for neurocritical care research at the University of Cincinnati. And now I'll turn things over to Dr. Foreman.
I'll unmute. Hi, great. Thank you so much. I very much appreciate it. Thank you for moderating, Dr. Brophy. It's my pleasure to be talking with you today. And the title of this is The Clinical Blind Spot. This section rather, is The Clinical Blind Spot, Understanding Nonconvulsive Status Epilepticus in the ICU. I should have control here. There we go. So to start off with, we'll start broadly. What is nonconvulsive status epilepticus? The ILAE, or International League Against Epilepsy, defines seizures and status epilepticus based on where they're coming from, their onset, and their clinical manifestations. So what many of us grew up calling generalized convulsive status epilepticus now has the term focal to bilateral tonic-clonic status epilepticus, and it's characterized specifically when you talk about status epilepticus as a time point one in which seizures are unlikely to stop, and that's just 5 minutes when you're talking about generalized convulsive status epilepticus. And there's a time point two, which marks the transition to neuronal and systemic injury. Now, what we used to call complex partial status epilepticus is really focal motor seizures with impaired awareness. And they're distinct insofar as their T1 is 10 minutes, a little longer, and a T2 is defined at something beyond an hour. And finally, there's non-motor seizures, or what we will call non-convulsive seizures. And they're really defined based on EEG as more than 10 minutes of continuous electrographic seizures, or seizures that occur more than 20% of a 60-minute EEG, so 12 minutes in total of seizure burden. And what's important here is that in the ICU setting, the vast majority of the seizures that we see are non-convulsive or non-motor. Seizures you can recognize standing at the bedside, those are really just the tip of the iceberg. Why is that, right? So on one hand, many of our ICU patients are intubated, they're sedated, and on the other hand, they're sick, even comatose in many cases, right? So notice that the prevalence of seizures in status epilepticus is remarkably high in some of the most severe disease processes that we care for in the ICU. So cardiac arrest, for instance, sepsis, traumatic brain injury, stroke, and in patients for whom clinical status epilepticus is treated, we think they've been adequately treated, they're no longer seizing clinically, nearly half of those folks continue to have electrographic seizures, and 1 out of every 10 have status epilepticus. Now, if we miss status epilepticus, patients are impacted. And when status epilepticus can be treated early, mortality remains low, as low as less than 5%. But the longer the patients have seizures, there's significant changes to synaptic receptors, to gene expression, and importantly, hemodynamic dysfunction develops that contributes to a pretty profound increase in mortality. The highest mortality occurs in our comatose patients with non-convulsive status epilepticus, and this is next to impossible to diagnose with our bedside exam. And there have been a number of studies that are increasingly coming out to show that the longer patients stay in status epilepticus, neuronal injury, moving past that T2 time point, impacts important patient-centered outcomes. So an increase, for instance, in the maximum hourly seizure burden of just 1% increases the odds for neurological decline by 13%. And for every hour someone spends in status epilepticus, there's a 10% increase in the odds of morbidity and mortality, and an additive worsening in cognitive scores. And in one study, the longer it took you to control the status epilepticus, it was an association with mortality and new onset disability 3 months later after the event. And you could see how long it took to control status in those who didn't do well. It was almost 2 or 3 days that passed before they were able to get control of the status versus just hours in those who did well. And we know that the earlier you treat with adequate doses of medications, the easier it is, the more likely it is that you'll be able to control that status epilepticus. So how common is non-convulsive status epilepticus? Well, there's one population-based study that estimates that non-convulsive status epilepticus occurs in about 12 per 100,000 people. And that's as incident as aneurysmal subarachnoid hemorrhage. It's close to the incidence of ARDS, actually, and 12 times the incidence of bacterial meningitis. So while not incredibly common, it's common enough that you're going to see it, right? And you have to have a low threshold to diagnose this. There was a small study that looked at the phenomenology of non-convulsive status epilepticus, and the majority exhibited a non-specific encephalopathy, just like many of our patients in the ICU. And there were some subtle clues, such as eye deviation, for instance, that occurred in nearly half, and that can be really helpful. but bear in mind that EEG remains really the only method to diagnose non-convulsive status epilepticus. Now, nationwide, fewer than 0.5% of patients are actually able to get EEG. Now, granted, over the 10 years of this particular study that looked at the nationwide inpatient sample from 2004 to 2013, there was a 10 times increase of EEG usage in patients mechanically ventilated in ICUs. Particularly in those disease processes we would imagine EEG would be useful for, such as status epilepticus or subarachnoid hemorrhage. Overall, fewer than 1% of patients admitted to ICUs undergo EEG to diagnose non-convulsive status epilepticus. Very low percentage. And so the question is why? Why are not more people being reported with EEG or having a diagnostic test to look for status epilepticus when we've seen those numbers? How many of those folks develop status epilepticus? If you look at your hospital system or your satellite hospital systems, the question is, how are you able to get EEG? And in many cases, the majority of the hours that patients are in the hospital, nights, 6 p.m., 7 p.m., right, they're insufficiently covered by EEG technologists. Those are, a valuable resource and a hard one to come by often. And in many places, our EEG technologists work normal hours. And so there's gaps in coverage where it may take people many hours to get an EEG hooked up. Now, the Neurocritical Care Society recommends continuous EEG within an hour of status epilepticus onset. Now, these guidelines came from the very prominent figures within neurocritical care, right, including our host, Dr. Brophy, who led this consensus guideline statement. But if you look at the recent DECIDE study, which was a study looking at EEG timing among 5 academic institutions, there was a median of about 4 hours to obtain EEG overall. And it was much longer after hours and on weekends, up to nearly 5 hours versus working hours. Now, in most ICUs, across most hospitals, this is a significant problem, right? This might reflect the workflow at your hospital, as you can see here, for instance, right? You may have a suspicion of status epilepticus, and hopefully after this talk, you do for some of your patients, right? And you order an EEG. But meanwhile, we have to do something. And so many of our empiric therapies lead to depressed levels of arousal, lead to intubation. And by the time the EEG technologist arrives, which could be anywhere from 2 hours to 2 days, depending on the institution, who's available, when they're available, they have to perform the hookup. They have to record the EEG. They have to get that data to someone who can look at it. An epileptologist interprets that data. And as quickly as they can find the ordering provider, they'll give them a call and let them know that this patient is in status epilepticus. But depending on when they're available or when they're sitting at their reading portal, that could take hours in and of itself. And finally, you have the diagnosis and you can treat, right? But at a time when technologies like point of care ultrasound exist, so we don't have to wait around for a formal echocardiogram to inform us of the critical decision making that we need to make and volume status and ejection fraction and that kind of thing. The time frame to obtaining an EEG, awaiting a read, making decisions, it's really not up to modern standards in most of our ICUs. So with that, I'm going to turn it over to Dr. Venkata-Subramanian.
Thank you, Dr. Foreman. And I think I have the controls. Let me just make sure. So I'm a stroke neurologist and a neurointensivist. And as a stroke neurologist, it's been drilled into my head that time is brain. But time is brain for status and for seizures as well. So Ceribell rapid EEG is a great complement to conventional EEG. Both have their specific roles and their specific places in the emergency room and in the ICU, and I'll walk you through this. So the point of care EEG, like Dr. Foreman mentioned, is like the point of care ultrasound. It is the first line stat reading in the ED and in the ICU when you really need the answer to a question. Is the patient seizing or not? Do we need to treat this patient or not? So it's a simple yes, no, go, no go question. Using this in the ED and in the ICU cuts down significantly on the time delays that Dr. Foreman was mentioning that we have even in well-resourced setting when we are ordering conventional continuous EEG. Now, conventional EEG has video on it. You can do it for multiple days, but what one has to remember is that we say it's continuous EEG. What it actually does is it's continuously recording, but there's nobody continuously monitoring and interpreting this EEG, the conventional EEG. On the other hand, a rapid EEG system, which has the addition of AI on it, and in this case, it's Clarity AI algorithm, it's not only continuously monitoring, it is not only continuously recording, but it's also monitoring and interpreting and giving the display as an output, which I'll show you in the next few slides. Plus, it has the ability to give a bedside alert to the providers for suspected status epilepticus. The algorithm is finely tuned to not miss status epilepticus and possible status epilepticus. So just like the POCUS, this is a point of care EEG, and the Ceribell system has three components to it. The first is the headband, as you can see right here. This can be placed by any provider with minimal training. For example, in my hospital, in the emergency room, it is placed by the ED technician. While we use it in the intensive care unit, it's placed by the resident or the APPs or by the fellow. So very minimal training, and depends on the hospital system who can place it. There are 10 electrodes. These are gel filled, so 8 channels, so 4 on each side. And then it's connected to a recorder, which is practically the size of your iPhone. And then there is a portal which can be accessed on your mobile device, or you can access it on the computer. So these, again, are the three components for the Ceribell entire solution. So you have the headband, you have the recorder, which the headband is connected to. The headband is a single patient use and can be left in place for up to 24 hours. Now, on the screen, you can also toggle and see the display about the contact of these electrodes on the skin. So if it is green, it means there is a good contact on the skin. If it is red, then it needs to be adjusted. It could be adjusting the position of the electrode, or it could be adding more gel into the electrode. So it can be left in place for up to 24 hours before the recorder runs out of battery and needs to be recharged. And then you have the portal, which again, I will bring up in the next few slides. On top of the system, we have Clarity AI, which is now in its 8th version. So this is the first FDA-cleared instantaneous bedside alert diagnosing electrographic status epilepticus in adult patients over 18 years of age. The display has several windows to it. So one window shows the seizure burden, and it shows it as a trend line. So you can basically see, is the patient having increased escalation of, seizures? How are they responding to the medications? There's another screen on the device which I have many medications listed on it. And the nurse who is giving it at the bedside can select the medication that is being administered. This will be annotated on the EEG, and thereby the provider, the reading epileptologist, can very easily see what the response to the medication is. So maybe, for example, you give 2 milligrams of lorazepam, and it wasn't sufficient, as Dr. Brophy loves to educate everybody to say, your initial first line is 4 milligrams of lorazepam and not 2 milligrams of lorazepam. So you can assess the responsiveness to a medication that you have given on the display as well. And then when we come to the portal has on the x-axis, we have the time, the duration of the recording. And then on the y-axis, we have the seizure burden. So the seizure burden is 10%, 50%, or more than 90%. If it is under 10%, then this is a quiet, slow, normal EEG. On the other hand, if it is over 90%, that is consistent with electrographic status epilepticus, and you have a display, the screen will turn red, and you have a bedside alert that will alert the bedside provider to say, hey, this patient is seizing. So what 90%, and Dr. Foreman will go into this in the next section, when the seizure burden threshold is 90% or above, what it basically means is for the last 5 minutes of the recording, 4.5 minutes of this were spent in electrographic status epilepticus. Now, on the top, as I was mentioning, you have these little syringes that tell us when the particular medication was administered. You can again look down and see what the response to that particular medication is. So, for example, let's take lorazepam here. So, lorazepam is given when the seizure burden is over 90%. There's very good response. The seizure burden comes all the way down to 0%. The response is not very lasting. The seizure burden goes back up. Levetiracetam is given that has a more sustained response. You have another breakthrough of seizures. Midazolam is given at this time, and it returns back to 0%. So this is a fantastic way to quantify the seizure burden and to look at the responsiveness to medications. Dr. Foreman already mentioned this, but I do believe it is worth reinforcing that non-convulsive seizures are highly prevalent in all of the neurocritical population that we see. You take any disease, you take after somebody has had a convulsive seizure at home, they come to the emergency room, they're a bit altered or they are not responding to commands, up to 50% of these patients have non-convulsive seizures going on. Similarly, with cardiac arrest, after they achieve ROSC and are not back to command following sepsis-associated encephalopathy and so on. The 2012 NCS guidelines for evaluation and management of status epilepticus, Dr. Brophy led this guideline. There is a clear recommendation to start continuous EEG monitoring within an hour of status epilepticus onset. With our current continuous conventional EEG systems, it is incredibly difficult and almost impossible to achieve this time metric. The guidelines from a variety of societies across a variety of disease states, again, let's take non-convulsive status, we can take post-cardiac arrest after return to spontaneous circulation, we can take ischemic stroke, we can take subarachnoid hemorrhage. All of these, when especially for ischemic stroke or for subarachnoid hemorrhage, when you have fluctuating levels of consciousness or this depressed level of consciousness, or the imaging does not explain why the patient is altered, these are all indications for proceeding with EEG monitoring. In the post-cardiac arrest population, up to a third of them do have seizures. When do these seizures happen? They can happen pretty much at any time. They can happen during the rewarming period. They can happen right after the arrest. They can happen after several days. And patients who have seizures have a 14 times increased risk of poor outcomes. Now, how do these seizures manifest? They can be silent. You may not have any external manifestation at all, or they could be subtle myoclonic movements. Now, the American Heart Association has a recommendation that a therapeutic trial of a non-sedating anti-seizure medication is reasonable in patients who have patterns on the EEG that are consistent with an ictal-interictal continuum. So let's look at two different case studies, one in a post-ROSC patient who had a highly epileptiform pattern, or HEP. So this is a 64-year-old woman who has a history of COPD, pulmonary hypertension, CKD, and so on, comes to the emergency room accompanied by her husband, brought in by the EMS because of altered mental status. She's essentially unresponsive. Her GCS is less than 8. Imaging of her head with the CT does not explain why she is encephalopathic comatose. Her ABG shows hypercapnia and respiratory acidosis. She quickly gets intubated. She also has AKI. And in the emergency room after intubation, she suffers a cardiac arrest. She's coded for 14 minutes, usual algorithms. Then she's placed on a propofol drip, given midazolam, and transferred up to the intensive care unit. In the ICU, she has movements that are concerning for a post-anoxic seizure, and Ceribell is applied at 12:43. So if you focus in on the display over here, so Ceribell recording starts around 12:43. For the majority of the initial period of the recording, the seizure burden remains less than 10%. You have occasional spikes up above 10%, but around 6:30, so 18:30, the seizure burden jumps up close to 90%. At this time, a dose of medication, midazolam and levetiracetam, is given. the epileptologist is called to look at the EEG. They are looking at it remotely, and they say it is consistent with interictal continuum. Midazolam is given again later in the day, and then the patient next day wakes up, is responsive, is extubated. So this is a great example of following through with the American Heart Association guidelines of using a non-sedating medication for patients who have interictal continuum patterns on the EEG. Now, the EEG in septic patients not only helps detect seizures, but it also, in a way, helps prognosticate the outcome of patients who are encephalopathic with sepsis. These are patients who are not sedated, they are encephalopathic. Let's say their EEG pattern has preserved reactivity, then that usually portends a good outcome. On the other hand, if the EEG pattern is very low voltage, if it is discontinuous, if it is completely suppressed, then these are patterns that are not favorable. They are highly associated with increased mortality as well. Again, to wrap up this section with a quick case study of a patient who had sepsis and who was mechanically ventilated. She's about 80 years old. She's on dialysis. She's septic, and she's admitted for an RSV infection, develops a secondary pneumonia. She's intubated for hypercapnia and hypoxia, and the sedation and pain medications are stopped after the initial intubation because her RAS remains pretty low and she's not waking up. At this point, the point of care EEG with Ceribell is applied, and very immediately you see that the seizure burden is up there at 90%, and the bedside alert goes off. This was later confirmed by neurology, but once the bedside alert goes off, the treating team gives lorazepam 4 milligrams. I know Dr. Brophy will be very happy with 4 milligrams of lorazepam there, and the seizure burden very quickly reduces down to 0. So this recording goes on for about 1.5 hours. You saw on the previous slide that recording went on for about 17 hours. So you can use it depending on the clinical scenario. And I will turn it over to Dr. Foreman at this point.
There we go. Great, thank you so much. Let's make sure I've got control now. All right, so the question then is, well, how does this algorithm work? So the seizure burden itself is this great number, right? But we don't like to think in terms of black boxes, right? So we want to understand a little bit more about how this artificial intelligence, when it's in action, is reliable. We want to understand how it works. We want to understand how we can use it comfortably in clinical decision making. So Clarity is the name of this algorithm, and it's an AI algorithm that's been trained on a massive data set approaching almost 1 million hours of EEG. It's a tremendous amount of EEG. And the way that it works is actually very simple. By training it on so much data, it's a simple labeling problem. The algorithm looks at a 10-second piece of EEG, as you can see on the screen here, and it simply labels it seizure or not seizure, based on all that it's learned from all of that EEG. And then over a 5-minute period of time, it just asks the question, how many of those 10-second windows I just labeled are seizure? And that is the seizure burden. So it's quite simple, right? So if you have 2.5 minutes of a seizure, your seizure burden will be 50%. Now, this has been validated compared to the interpretation of expert EEGers who are also labeling seizures on EEG across multiple different hospital systems. And this algorithm's been iteratively improved over time, as good AI is. And its current version, it has a specificity of 97% and a sensitivity of 95%. For the detection of status epilepticus when that seizure burden number goes above 90%. Now, if you look in the blue bar, you can see those numbers I just gave you, right? 97% specificity, 95% sensitivity. And in the gray bars are actually the reviewers that this was compared against. And you can see the sensitivity is just as good, if not better. And the specificity is really on par with the expert EEGers who were looking at that raw EEG second to second and making an adjudication on whether seizures were present or not. Now, perhaps even more importantly, the majority of your patients are not seizing. In fact, if you were using point of care EEG and everybody you hooked up was in status epilepticus, you're probably not hooking up enough people and missing some. But in general, more than 2/3 of the patients that you use point of care EEG on have a 0% seizure burden. And I would argue this is actually just as important, if not more so, than picking up on some of those patients who have focal seizures and status epilepticus, because it changes your complete mindset about that patient who prior has been a rule out status epilepticus patient, and now you can focus on other differential diagnoses. A seizure burden of 0% has a negative predictive value that's almost 100%. So it's something you can sort of take to the bank and say, all right, I know this patient's not seizing. Let's move on and figure out what's actually going on. So as Dr. Katasubrahmanian mentioned, the Ceribell EEG can be accessed in the cloud via a secure website. And here's an example of what that looks like, as you've already seen. But this is a real example, real page out of the cloud. And you can see the raw EEG above it. But I would imagine most of you guys don't stare at squiggly lines all day long. And so I want to draw your attention to the bottom, which is the seizure burden of this 5-hour EEG recording. And using this, you and I can see the whole EEG without having to manually interpret it. And oftentimes we don't have time to do that, right? We need to make a decision. We need to understand what's going on. And so certainly you could, and many of us do, look at the raw EEG, but that summary, essentially, of what the seizure burden is over time is really, really helpful. In this case, you can see if you look at the raw EEG, there's a left hemispheric, very rhythmic, evolving pattern that's consistent with seizure. And in that seizure burden down at the bottom, you can see that it ramps up to 90%, meaning this pattern is occurring for 4.5 of the 5-minute window that it's calculating that seizure burden on. And so you can see it sort of adds up over the first 5 minutes, right? It first starts, it's got a minute, and most of that minute is seizures, but it's got to crawl across about 5 minutes. And then it says, okay, now I can calculate it. Oh, it's 90%. So you can see it slide up the first 5 minutes, and now it's at 90%. Now, if you look at the annotation, you'll recognize, at this point, that there's an annotation there for lorazepam, so you can see when that's tagged. And the status epilepticus, of course, is aborted fairly quickly and doesn't recur. But those screens, that you can look at give you a wealth of information from 5 hours of EEG very quickly, just at a glance, right? So you can see how quickly this technology has developed from initial device clearance 6 years ago through the process of obtaining breakthrough device designation, in-tap reimbursement, and now approval for use across the age ranges from 1 year to adult. And we're currently at Clarity version 8. So again, it's iteratively improving every single time, and we're in version 8. And there's a reimbursement structure that more than 500 hospitals are taking advantage of to care for more than 200,000 patients at this point. I want to show you an example of how this makes an impact, and this is a real case from our shop. This is a 76-year-old patient who arrived to the ICU after being treated for generalized convulsive status epilepticus. And he was treated, treated with sedating agents, and so he was unresponsive on arrival to us in the ICU. Now, our normal is that we await, a continuous EEG, assuming that we've treated the generalized convulsive status epilepticus. We assume that it's resolved. He just is going to need some time to wake back up. But in this case, we said, we need to know, because we either need to take this guy off propofol, get him to wake up, if that's the case, right? Or we need to give him some more time, or we need to do something else if he's still seizing. And so we placed the Ceribell. It was very clear right up front that the status epilepticus was still ongoing. And you can see that seizure burden as it ramps up. Boom, you hit almost 100% in this case. This patient's in status. So we were able to very, very quickly pull some lorazepam out of the medication administration system we use and give it immediately, along with a load of an anti-seizure medication. And as you can see here, as we sequentially give those medications, the seizure burden drops to 0. And that time frame on this bar is about 20 minutes. Now, our hospital is actually really lucky. We have 24/7 EEG coverage. We have technologists that are fantastic, and they're super, super fast. But even so, continuous EEG was hooked up about 2 hours later, which is better than the median from the DECIDE trial because, we do a good job. But that's still 2 hours that this patient would have been in status, even in the best of circumstances, right? So the seizure burden here is really, really useful to try to get that under better control. But anecdotes are not evidence, I recognize. So decisions based on point of care EEG are, I think, clearly impacted by information gain at the bedside across a number of places across the country. And I've seen each of these sorts of cases in my institution. There was a survey rather of 17,000 different folks, and 37% of those folks said that when they used point of care EEG, they saw improvements in their decision making. Nearly half said they were able to avoid anti-seizure drugs. 1 out of every 5 were able to avoid an intubation in somebody, and more than 40% were able to avoid needing to move someone to the ICU or transfer out of their institution for EEG monitoring. That stuff's huge, and I've seen that myself in a number of patients over the years as we've been using point of care EEG. The Safer EEG study was a retrospective look at adults undergoing EEG during hospitalization across 3 different centers. And when they compared patients who were matched by age and diagnosis and severity of illness, who underwent our normal conventional EEG versus using point of care EEG in their system of care, they found that this actually made a big difference clinically. So critical information was obtained about 5 times faster when Ceribell was used. So they were able to get information within about 6 hours relative to more than 24 hours. And by having the information earlier, they were able to make decisions. And the result is that patients' ICU length of stay was cut in half. And even as early as the time of discharge, which is a really early endpoint for most of our ICU studies, right? Nearly 1 in 5 patients already had better recovery than the folks who had undergone conventional EEG. So with that, I'm going to turn it back over to Dr. Venkata-Subramanian for the last section of the talk.
Thank you, Dr. Foreman. Let me make sure I have controls again. Okay, so the last section I'm going to wrap up on how do we actually implement this technology in our clinical practice, and I'll draw a little bit on my own experience at Stanford as well. So before we get there, when do I, as a neurointensivist, suspect non-convulsive status in a patient who is altered, who is encephalopathic? So these are 4 common rules that I kind of think about it. One is if a patient has an acute decline in their mental status, particularly it hasn't been going on over days, but it just happened in the last 24 hours. My suspicion for non-convulsive status also increases the lower the GCS is. So lower the GCS, more I'm suspicious of non-convulsive status and seizures. If the imaging, so CT or MRI, doesn't show any structural injury to explain why the patient is altered or comatose. If the laboratory findings are unremarkable or only slightly out of whack, and they don't really explain why this patient is encephalopathic. Now, the thing to remember is you can do all of these investigations in parallel, and you don't have to wait for one after another and waste time in it. So for example, take the patient to the CT. CT looks fine. You're drawing the labs, and you can connect the Ceribell system right away. And you'll get a quick answer from it. Finally, when the patient's presentation is completely out of proportion to the primary diagnosis. So for example, patient has a small lobar hemorrhage, but the patient's GCS is 10. Well, that hemorrhage doesn't explain why the GCS is so low. So I'm going to look for an additional explanation for that. There's not significant edema around it. So I'm going to put on a rapid EEG and make sure that the patient is ruled in or ruled out for seizures. The Accurate study was an independent study done by investigators out of Yale. They had 235 sequentially sampled and de-identified adult cerebral EEG studies from 3 of the hospitals in the Yale system. Now, the objective of this independent study was to evaluate the performance of the 6th version of Clarity. Right now, it is in the 8th version or 8th generation of Clarity, but this was evaluating the 6th generation to detect electrographic status epilepticus and possible electrographic status epilepticus. and looking at how good it is when compared with the gold standard. So what was the gold standard here? The gold standard was 2/3 majority consensus of the reading electrophysiologists or epileptologists who were reviewing in a blinded fashion the EEG readings. The key results from this study was that Clarity version 6 delivered high specificity, so 99% specificity and 78% positive predictive value for ruling in status and possible electrographic status when the seizure burden threshold was set at 90%. On the flip side, at 10% seizure burden threshold, Clarity was equally impressive in having a sensitivity of 88% and negative predictive value of 88% to say, hey, this patient is not in electrographic status or possible status. So based on these results, the Yale authors proposed that Clarity can be used and should be used as an adjunct tool that informs clinical decision using these three criteria. First is what the seizure burden threshold is. Second, does that institution has availability of continuous EEG? And does the institution has availability of an expert reader? So they came up with two proposed workflow algorithms, which I'll walk through in the next couple of slides. So the first one is a workflow example based on the Accurate study in a center where there is stat reading availability. So we are dividing the seizure burden into 4 different buckets. So let's say the seizure burden is 0%. The recorder, is displaying 0%. There's no seizure alert that's going on. At this point of time, there is no indication to treat. You're going to ask for a non-urgent EEG review, probably the next day. You don't treat, just monitor. If the seizure burden is between 1 to 49%, again, we're not treating yet. We are continuing to monitor and we request for an EEG review, especially if the seizure burden continues to climb. If the seizure burden, let's say, is 50 to 89%, these are likely short seizures. We are preparing to treat or may treat, and we're asking for a more rapid stat EEG review because the institution has a stat reading availability. Now, if the seizure burden is more than or equal to 90%, the bedside alert is going off, continuous seizures are detected, we are treating, and then asking for a stat EEG review. So there's no time delay between recognition and treating and reviewing. Another example where there is not a stat reading availability in that institution, we are going to use the same 4 buckets. We're going to divide it into based on what the clinical suspicion is. So is our clinical suspicion high or is our clinical suspicion low? So let's say 0% clinical suspicion high or low, we're not treating, we're monitoring, and we're asking for a non-urgent EEG review. If the clinical suspicion is, again, high, and the seizures are between 1 to 49%, the seizure burden, or 50 to 89%, we're not treating or preparing to treat, and we're requesting for an EEG review, particularly if the seizure burden continues to worsen. On the other hand, if the clinical suspicion is low, you don't have to treat, you're going to continue to monitor and ask for a priority EEG review, especially if the seizure burden is close to approaching 90%. Now, if it is 90% or above seizure burden, we go back to the same treatment, i.e. you treat and you ask for an urgent EEG review. So how do we use it at my institution? These are some of the indications for which we use Ceribell and continuous EEG. So these would be status epilepticus, where the patient has not returned to baseline consciousness. In vascular pathologies, where there is a discrepancy between the imaging and the clinical status of the patient, or if there's fluctuating level of alertness of the patients. Post-cardiac arrest, particularly patient comes in at night. Post-cardiac arrest, we might start off with a rapid EEG before transitioning over to a continuous EEG, where patients can be monitored for multiple days, and so on. Now, practically, how do we implement rapid EEG with Clarity at Stanford? And this has gone through multiple iterations, and our current iteration is as follows. And I'll tell you in the next slide where this current iteration came from. So all EEGs at night are initiated with rapid EEG. And then depending on the seizure burden threshold, we either treat or we call the EEG team. Any EEG that is obtained in the emergency room is a rapid EEG. Now, it's notoriously impossible to get a conventional EEG down in the ED, so the emergency room physician, they put on the rapid EEG right away. All EEGs in the PACU are rapid EEG with the Clarity Edition. When we have spot EEGs, a very short amount of time that we're monitoring patients. Now, this is an interesting one. One might say, well, you're at a very well-resourced institution. That's true, but we run out of EEG machines all the time. And we play this Russian roulette as who do we unhook and who do we hook onto the EEG. Now we don't have to do that because we have rapid EEG available. And then during the height of the COVID pandemic, any COVID-19 positive patients were hooked on to the rapid EEG with Ceribell. Now, this new algorithm, especially about the nighttime EEGs, came as a result of being mindful of the work-life integration of our epilepsy colleagues, and has made a huge impact on their healthcare providers and their quality of life. So we kind of, have a little moniker to say, normal or slow EEG, we call it green. So green means clean. Don't bother anybody. Don't wake up anybody. Green's clean, so good. If it is a highly epileptiform pattern, we call it yellow. So just like a traffic light, right? Yellow, call the EEG fellow. And if it is red, i.e. more than 90%, seizure burden threshold, red means give med and then give the clinical review. So green means clean, yellow, call the EEG fellow, and red is give med. And this kind of pivot to particularly the nighttime EEGs with Ceribell EEGs has made a huge impact on not only work-life integration, but really rapid diagnosis, rapid identification of seizures, rapid treatment, and improved outcomes. So wrapping up with the last couple of slides, a couple of sample workflows from patients with post-cardiac arrest and for patients who have encephalopathy. So based on the American Heart Association guidelines, after achieving ROSC, if the patient is not back to command following, so for example, they may be agitated, but they're not back to command following, this is certainly an indication to start EEG monitoring. The AHA recommends promptly performing and interpreting EEG for the diagnosis of seizures in patients who do not follow commands after ROSC. And for patients who come in with an acute neurological change or altered mental status or encephalopathy, again, EEG with a rapid EEG in this setting is definitely a part of the toolbox that we use along with imaging and along with other lab work, such as glucose checks or ABGs. If you put on the EEG and you find that the patient has non-convulsive status, we are monitoring the seizure burden, and we're, of course, treating per guideline. If there is no seizures, monitoring at least, we would recommend at least for 2 hours. We're continuing to look for other causes of why this patient may be encephalopathic. So I will wrap up there and we will go on to the moderated Q&A section.
Thank you so much, Dr. Venkata Subramanian and Dr. Foreman. That was a very wonderful presentation, so much information, and thank you for incorporating your practice as well. We do have a couple of questions from the audience, and I would again encourage anyone who has questions to please feel free to submit them to us. You can do that anonymously if you'd like to as well. So we do have one of the first questions that we got was looking at the Ceribell and knowing that you guys are using it in different ways in your institutions. I'm wondering, this audience participant would like to know if the Ceribell has actually impacted the number of EEGs that are actually being done since it was approved with the Clarity device.
I am unmuted, so I'll probably, take the first stab at it. So The patients for which we are doing EEG monitoring, the indications certainly have not changed between using rapid EEG or continuous EEG. I guess the question, if you're asking, has there been an increase in the number of patients we are monitoring with EEG? I would say there has been at least a slight increase in the patients that we're monitoring with rapid EEG, but these are patients that would have been monitored maybe the next day, for example, with continuous EEG. So we are using the rapid EEG as part of our initial diagnostic tools for workup of patients who are encephalopathic. Dr. Foreman, do you have a different experience?
Yeah, no, I think that's true. It's kind of hard to compare before and after because there are some patients who are using it, you're triaging, and they may not end up needing continuous EEG. But I would also argue, and I've heard this kind of reflected over other hospital systems, that you end up also screening the more patients with rapid EEG. It's easier to get. You can hook more people up essentially. And in some places, there's actually been an uptick in the transition to continuous EEG because these are patients you wouldn't have picked up on abnormalities before. So I would say, it kind of depends on the system of care, but in general, if anything, it's actually impacting this by increasing awareness, increasing the use of continuous EEG in some cases, but certainly at least increasing the amount of patients who actually are getting the right diagnostic tests.
Very good. Thank you both. We have another question looking at patients in the ICU who come in due to convulsive seizures with or without status. And they were wondering if you have any information on the prevalence of non-convulsive seizures in those patients while they're in the ICU. It said they had mentioned a slide looked at that you presented looked like this might be up to 50% in some of those patients.
Yeah, that's right. So this is actually a relatively old paper, but it was so striking and it's been replicated. But what they had found is one of the earliest papers where they were looking at EEG, and specifically in those patients who came in with generalized convulsive status at that time, it was 48% of them who went on to have seizures on EEG, and it was 10% that were in frank status epilepticus. The bar was a little higher back then. It's probably a little higher based on our current definitions. But that, that literature, I think was really, really striking. And it was, like I said, a number of years ago, but we see it, I think those numbers bear out in clinical practice too. It's very, very common.
All right. Thank you very much. Another question for you. We have an EMS, some personnel on the line, and they would like to ask regarding the fact that they don't have EEG or, the rapid EEGs on their ambulances. And given the prevalence that you mentioned about non-convulsive status or seizures after ROSC or post-cardiac arrest, they're wondering what your opinion is on potentially giving a longer-acting anti-seizure medication such as levetiracetam during the long transports in the absence of having this rapid EEG monitoring on the ambulance service.
Yeah, I'll take the first stab at this one. So these are the recommendations from the AHA. I think I had put it up in one of the slides, is for patients who have achieved ROSC and who aren't back to command following. If it is going to be a very long period of transport or very long period of time where you're not going to be able to monitor the patient, I would say it's reasonable to use a non-sedating anti-seizure medication. So the AHA says if you see on an EEG an ictal interictal pattern, so it's not frank seizures, but it's kind of on the borderline, the recommendation is you can certainly consider a non-sedating ASM for this. Now, are we in a position to extrapolate this to the ambulance where it's going to be a long transport time, or going to a facility where they don't have EEG monitoring, they don't have access to rapid EEG? I would say probably, but using a non-sedating medication is very key, and this would be a great opportunity for that facility to bring on EEG monitoring systems as well.
Yeah, I think the the key thing for this question is there a role for actually point of care EEG in EMS? I think the answer is yes. It seems like sort of an ideal situation where you need information and you need it quickly. My opinion on prophylaxis is a little bit, colored by the fact that there's not a lot of recommendation for it for many of our diseases. And I'm always reticent to recommend it, without having the data. And I think one of the powers of point of care EEG is that in many cases we choose not to give an anti-seizure medication because the patient's not seizing. But I think it calls really to, I think more importantly, I think it calls for the need for that information upfront and early. So spearhead it, because that would be super cool. And I think actually a really useful bit of information for a lot of different patients, not just the ROS patient.
Yes, very good. I agree completely. I think that would be great. The more data, the better, as we always say. We also have another question regarding, do you think Ceribell actually would replace our conventional EEG in monitoring patients with status epilepticus, or where do you feel it falls in practice?
So, I work across two hospital systems. One is, of course, Stanford, and we have a community hospital system. So when patients come in with status to our community sites, they are using Ceribell EEGs as their go-to device for monitoring patients with status. And the headband can be left on for up to 24 hours. You certainly have to do skin checks, every couple of hours to make sure there's no skin breakdown and make sure that the leads are in, proper contact and make sure that the gel is filled. But in that system, they are essentially using Ceribell EEG as their EEG monitoring for patients who have had status, been brought in, at least for the first 24 hours, to make a decision whether they need to transfer the patient to a higher level of care. So in that setting, at least in the community system that is affiliated to my hospital, they have replaced continuous EEG monitoring with Ceribell, at least for the first 24 hours.
Yeah, I think the use of it as a bridge is probably one way to think about it. And that bridge may be very short if you're at an institution that has fairly quick continuous EEG and techs that cover things 24/7. In many of our cases, it's going to be a longer bridge, in that patient we feel like needs it, and up to 24 hours, you mentioned. So I don't know that it replaces it, but within that period of time where you're bridging, you can treat the patient, get to the other side and figure out, well, maybe I don't need it at this point because we've got things under control or we've adequately, screened and triaged and made sure that patient's not seizing. So as a a bridge, I think it really fits in, but I wouldn't say it's a replacement. I think there's a big role for continuous EEG monitoring, especially in folks who have seizures that are delayed 24, 48 hours in many of our, acutely brain injured patients. But in particular, consider your hospital system too, because if there is nothing to bridge to, then it's not a replacement. It is the tool, right? So just it depends on the system, I think, more than anything else.
Very good. Another question, I think we have time for maybe one more here. Is a question regarding the use. One of the participants here today, they use Ceribell on the nights and weekends when video EEG is not available. And they're wondering about the risk of inadvertent undertreating of nonconvulsive seizures due to maybe the these rapid EEGs, and is that a possibility?
Yeah, that's a good question. Well, I think where you get into this situation where there's, I suppose, under treatment, or maybe where there's some nuances when the seizure burden is not above 90%, it's not zero, and you're in a gray zone where that patient may be having very frequent focal seizures, and the seizure burden's 50, 60, 70%, or they're having very frequent ictal and interictal discharge patterns that are very clearly associated with the risk of developing unequivocal seizures in status epilepticus. then in that case, you might have a situation where there's maybe not the treatment you would expect to give if it was more than 90% based on your algorithm at your hospital, right? Or something like that. So I think there's a role in that gray zone where you say, I need someone to be able to look at the raw EEG if I can, to try to make a decision if I am unsure. Or, in some cases, using those higher seizure burdens, or maybe they're not above 90%, but using those to empirically cover, just because there is a sensitivity and specificity is pretty high for focal seizures, even if it may not fit criteria specifically for status epilepticus, right? And part of the reason I say this is the definition is 20% of any 60-minute EEG, so 12 minutes of seizures over the course of 60 minutes. And a seizure burden of 90% is 4.5 minutes of seizures in a 5-minute window. So you can imagine you could have 2-minute seizures 6 times over the course of an hour, and that's status, but your seizure burden may only go up to 70 or 80%, maybe 60%, right? And then come back down. So I actually use the cloud, that seizure burden trend over time, because it often can tell you that patient's having recurrent seizures just by the way it looks. And that can be really helpful too on those nights and weekends where someone just has to come and spot check it. It becomes a really straightforward way to quickly do that.
And may I just add one thing? I was reading the comment here. So parasagittal seizures in adults are extremely, extremely rare. So it's less than 1% for adults. So I completely agree with what Dr. Foreman was saying, is like, look at the pattern and the trends over time to make a determination of whether you want to treat or not. But parasagittal origin seizures and focal seizures in adults are extremely rare, like less than 1% of all the seizures.
And that's something others have looked at too, just by taking a scalp EEG, taking off the parasagittal electrodes and asking, well, how many seizures do we miss? And really the answer is very, very few. And actually none of the patients who had seizures were missed, even if 1 or 2 happen to be so focal. But it is exceedingly rare to have something it's a focal midline parasagittal seizure in adults. I completely agree.
Well, thank you so much. That concludes our Q&A session. I'd like to personally thank both Dr. Venkata Subramanian and Dr. Foreman for their wonderful presentations today. I think we all learned a lot. And I'd like to thank you to the audience for attending today. Again, this is a webcast is being recorded, and the recording will be available to the registered attendees within 5 to 7 business days. You can log into your mysccm.org to navigate to the My Learning tab and click on the webcast, Nonconvulsive Seizures in Critical Care, the emergency you can't afford to miss. And then once you click on that, you will click on the Access button to access the recording. So thank you again very much for attending, and that concludes our presentation for today.